Welcome to Department of Medicine Grand Rounds. I hope you will accept your pinch hitter today. Dr. Armstrong is performing her civic duty as a juror. And so I have the pleasure of introducing our speaker today. So Dr. Alanna Morris is well known to so many of us, and we are very excited to hear her updates and perspectives today. She joined Emory and the Emory Clinical Cardiovascular Research Institute in 2013. She received her undergraduate degree in biology from Xavier University of Louisiana and her medical degree from Harvard Medical School. She completed her residency at Brigham and Women's Hospital in Boston, and subsequently she came to Emory University to complete fellowships in general cardiology, advanced heart failure, and transplant. After completion of her fellowship training, she was appointed assistant professor of medicine in the Division of Cardiology, and her clinical time is spent as the director of heart failure services at the Atlanta VA Medical Center and as faculty for Emory Center for Heart Failure Therapy and Transplantation. Her research interests include studying the importance of non-modifiable risk factors, such as race and gender, that may contribute to excess disease in high-risk populations, and identifying the role of biomarkers of oxidative stress and endothelial dysfunction in patients with heart failure and reduced ejection fraction. Finally, her research also examines the important questions of race and gender-based differences in outcomes after heart transplantation and LVAD implantation. And she's here today to share updates in treatment pathways for patients with heart failure. We are very much looking forward to your presentation. Thank you, Dr. Morris.
Thanks so much, Karen. And I'm actually not at the VA anymore. I still miss those days, but just because I don't want you guys to start consulting me for
my mistake on that. Sorry about that. Thank you.
That's okay. So we're going to spend some time today talking about sort of the rapid change in treatment pathways for patients with heart failure. So thanks for the invitation. These are my disclosures. And we got a lot to discuss. As you guys know, things have sort of changed dramatically in a relatively short period of time. So for the purposes of the next, hopefully 50 minutes or so, I'll try to leave some time at the end for the discussion. We'll review the new universal definition of heart failure, as well as the role that biomarkers play in that definition. We'll review new evidence for medical therapy in both HFrEF and HFPEF. Excitingly, we now have some FDA therapies for HFpEF. And finally, we'll review appropriate treatment pathways for patients with worsening heart failure. So you guys know probably even better than we do on the Advanced Heart Failure Service that heart failure is associated with extremely high morbidity, mortality, as well as costs. I think this has sort of been in the forefront of many of our minds, in part because we care for these patients in hospital settings in particular, but since the initiation of the Hospital Readmissions Reduction Program back in 2014 and the excess penalties that are associated with excess readmissions, this has been something that all of our clinical care groups, I think, have been having to think about. The prevalence of heart failure is extremely high, about 6.2 to 6.5 million cases in the US, almost 1 million new cases every single year. Mortality, we still sort of quote 50% at 5 years, even though there's a few data sets that show slightly better numbers like 42% at 5 years, but still substantially high. Over 1 million hospital discharges a year and a cost estimate of at least $30 billion, but that's probably an underestimate. And we know that the major cost driver of heart failure is this high incidence of hospitalizations. I'm actually submitting a grant in a couple of days, so I've reached out to a few of you in the last few weeks to ask for data and letters of support. But in terms of some of the data that I've collected recently, heart failure may be the third most common DRG within Emory Healthcare. So we see a lot of heart failure here. So it's important for us to think about how to optimize care for these patients. This is some data from the American Heart Association Get With The Guidelines registry that looked at 5-year outcomes for elderly patients, so patients over the age of 65 that were hospitalized with heart failure within hospitals within the Get With The Guidelines registry. And you can see there's a mix of ejection fractions here. So about 46% were reduced EF, 46% preserved EF, and about 8% had borderline EF, or what we're now calling mildly reduced, which is EF, so 41 to 49%. And you can see a couple of things from this slide. Number one, if you look at the cumulative incidence of mortality, it doesn't differ by ejection fraction. So again, there's sometimes this concept that patients with reduced EF have worse outcomes than patients with HFpEF, but that's actually not true. And then when you look at sort of the 5-year event rates for these patients, mortality is 75% at 5 years. If you look at a combined outcome of mortality and readmission, it approaches 100% at 5 years, maybe with slightly more cardiovascular and heart failure specific readmissions in patients who have HFrEF or heart failure with mildly reduced as compared to PEF, but still an extremely high incidence of adverse outcomes for these patients. And we know it's important for us to think about this because the prevalence of heart failure is going up. So of course, in part because of the aging of population, but because of the increased incidence of obesity-related diseases, obesity itself, but also diabetes, hypertension, sedentary behavior, we know that we're going to see more and more heart failure with, of course, important disparities by race ethnicity, with Black Americans having the highest incidence and prevalence of heart failure, followed by white non-Hispanic and then Hispanic Americans. So because of this sort of huge burden in terms of the epidemiology of what we see, a group of experts sort of got together early last year and actually really redefined heart failure for us. And this is this new universal definition of heart failure. And that is symptoms and or signs of heart failure that are caused by a structural and or functional cardiac abnormality. It has to be corroborated by at least one of the following. Your patient either has to have elevated natriuretic peptide levels or objective evidence of cardiogenic pulmonary or systemic congestion. These are the natriuretic peptide levels that define heart failure, sort of based on this universal definition. So if you're in an ambulatory setting, like clinic, and you decide to check a BNP or an NT-proBNP, of course, in our hospital system, we're still using BNP, but either are fine. It's a BNP greater than or equal to 35 or an NT-proBNP greater than or equal to 125. If somebody's in an ER setting or in the hospital with acute decompensated heart failure, it's a BNP greater than or equal to 100 or an NT-proBNP greater than or equal to 300. And so, I mean, I think, of course, it's important for us to sort of take a step back and think about the physiology of the natriuretic peptides. They're released, or proBNP is released in response to distension and stretching of the left ventricular wall. There's also AMP that's released from the atria. But that proBNP is cleaved to NT-proBNP, which is biologically inert, as well as BNP, which is biologically active. So we know that BNP has multiple effects throughout the cardiovascular system that enhance natriuresis and diuresis. It actually increases GFR by relaxing mesangial cells. It inhibits tubular fractional reabsorption of sodium. It decreases vascular resistance by relaxing vascular smooth muscle throughout the body. And so there's a ton of these sort of biologically active effects or effects of the biologically active molecule BNP. But as I mentioned, depending upon what your hospital system checks, it's also fine to follow NT-proBNP because we know that some of the novel medications that we'll talk about later have maybe differential effects on what you see in terms of levels of NT-proBNP versus BNP. It's also important to realize that heart failure is not the only thing that can cause an elevation in either of these biomarkers. And so, of course, on the consult service, we'll sometimes see, consults for elevated troponins even, or elevated natriuretic peptides. And of course, we know that not all elevated BNP is heart failure. Of course, BNP can be elevated from a number of cardiovascular causes. I'm not going to read this list because it's fairly exhaustive. It can also be elevated from a number of non-cardiovascular causes. And this is where we sort of have to put our hats on as clinicians and decide, do we think this is true acute heart failure? Is this, sepsis or a bad stroke or some other process? And sometimes that can be difficult to ascertain. And of course, sometimes the picture can be mixed, but it's important to realize this. On the converse, we also know that many patients with heart failure, with acute heart failure, bona fide, don't have significant elevations in their natriuretic peptides, particularly those patients who are obese. There's more and more data suggesting that patients with African ancestry have lower levels of natriuretic peptides than one might expect. So just because the natriuretic peptide is not elevated does not mean that your patient doesn't have heart failure. So again, we have to use our clinical judgment. But the reason why this is important, of course, is because most of the recent clinical trials in heart failure have really used the natriuretic peptides, in particular NT-proBNP, to define who gets into the trials. So as we talk about and sort of think about the novel medical therapies that we'll spend the majority of the time talking about, it's important to sort of put this into context. Because most of these trials have really sort of tried to isolate patients who have true heart failure with different cutoffs for patients who are in sinus rhythm versus those who are in atrial fibrillation or atrial flutter, because we know that that in and of itself can elevate natriuretic peptide levels. And particularly for those patients who have HFpEF, who were included in Paragon and Emperor Preserved, we really do have sort of this natriuretic peptide cutoff that helps us define that their dyspnea on exertion, that their symptoms are true heart failure and not deconditioning from severe obesity or dyspnea from COPD, if you will. So I think the other thing that was important in this universal definition document was that it redefined the stages of heart failure. So most of us probably learned the older ACC/AHA classifications of heart failure, stage A, stage B, stage C, and stage D. And those have now been redefined. So patients who we used to call stage A are now being called at risk for heart failure. So these are patients who don't have any current or prior symptoms or signs of heart failure. They don't have any structural or biomarker evidence of heart disease, but they do have risk factors. They have hypertension, they've got diabetes, they've got obesity. Maybe it's a woman who's about to get anthracycline treatment for breast cancer therapy. And these are all patients who are at risk for going on to develop heart failure. Pre-heart failure is now what we used to call stage B. So again, these are patients who don't have current or prior symptoms or signs of heart failure, but they do have evidence of one of the following: structural heart disease, which could be left ventricular hypertrophy, chamber enlargement, including the atrial wall motion abnormalities, abnormal cardiac function, including diastolic dysfunction, or elevated natriuretic peptide levels. And the reason that it's important to sort of recognize this is because there's been a couple of small randomized controlled trials that have shown that initiating GDMT in patients who are stage B or pre-heart failure can actually prevent the onset of heart failure. And those trials were actually sort of prior to SGLT2 inhibitors and other medicines that we have now that we clearly know can prevent the onset of heart failure. So it's important to think about these patients in the pre-heart failure category and consider checking natriuretic peptides, even as an outpatient, to sort of further risk stratify. Of course, we know that patients who are stage C or have manifest heart failure are those who have current or prior symptoms or signs. And I think the thing that's important here is to sort of realize that with good initiation and titration of GDMT, we can get these patients into what we're now calling remission. So we don't want to say that patients are clinically stable, but we want to say that their heart failure is in remission, including those patients who have a recovery of their ejection fraction or an improvement in their ejection fraction after GDMT has been initiated, because we actually don't want to withdraw that GDMT. And then, of course, we tend to see in the inpatient setting patients who have persistent heart failure. And it's more and more important now to recognize that some of those patients are actually advanced or have stage D. We know that stage D is grossly underdiagnosed, that many of these patients, unfortunately, only present when they're in extremis. And then they're requiring, pressors, inotropes, ECMO. And we really want to try to diagnose these patients earlier in the course of their disease so that we can really sort of try to decide what are the best therapies for them. So again, this is a little bit of a paradigm shift for, I think, most of our training. There's been a lot of emphasis on preventing coronary disease and talking to patients about hypertension, diabetes, obesity as risk factors for coronary disease. But we also really want to think about heart failure as a condition that can be prevented, particularly now that we are in sort of a setting where we have therapies for comorbidities that can prevent the onset of heart failure. This is some data that I put together with one of our current cardiology fellows, just looking at sort of the prevalence of heart failure stages across community cohorts. So if you think about those patients who are stage A or at risk, or stage B, or we're now calling pre-heart failure, these are the patients that actually make up the bulk of the patients that we take care of, particularly that our medicine and family medicine colleagues take care of in community settings. And of course, the patients who have stage C or stage D, even though they're the ones who we tend to see the most and probably consume the most resources, they really are the minority of the patients that are out there. I think this diagram also highlights differences in terms of gender and race. We know that Black patients in particular tend to have more heart failure onset, in part because of the higher burden of traditional comorbidities. For example, in one of these cohorts, which is the HErEF cohort, the Jackson, Mississippi side of the HErEF cohort, actually 98% of the participants were classified as having stage B or pre-heart failure, simply because they had evidence of left ventricular hypertrophy, which we know is a risk factor for incident heart failure and cardiovascular disease. So we really want to try to place an emphasis on prevention so that we can prevent patients from going on to stage C. So again, in those patients who are at risk, we have to talk to patients about the fact that their lipid abnormalities, their insulin resistance and diabetes, their hypertension, their obesity, in and of themselves are all risk factors for the development of heart failure, even if there's no sort of antecedent coronary disease or antecedent MI. And the relationship between these cardiometabolic risk factors and the onset of heart failure may be even stronger, or probably is stronger, for women who tend to have more microvascular dysfunction and disease as sort of the etiology of their heart failure, as well as patients from race ethnic minority groups, again, who tend not to have coronary disease or an MI as sort of the preceding factor between these risk factors in the development of heart failure. We know that these comorbidities are sort of particularly important as we think about HFpEF, which I think for many of us can be a very confusing entity. In truth, this is an entity and a syndrome that we're redefining, even though we now have therapies to treat it. But again, in part, we know that these comorbidities tend to increase inflammation, and that inflammation, both in the periphery as well as the level of the myocardium, actually causes this sort of multi-organ reserve dysfunction. So it's not just diastolic dysfunction, as we often say. It's issues with lung reserve, it's issues with adiposity, it's issues with skeletal muscle dysfunction, and of course the kidneys are important. And so all of these different comorbidities are important to treat and try to get to goals so that we can help manage the HFpEF syndrome itself, because it really is sort of a multi-organ syndrome. So how can we optimize care for chronic HFrEF? We'll talk about HFrEF first. And I think, one of the things that we see and do as clinicians, because again, there's so many of these patients, we know that clinical inertia is a real issue for many of us because we're busy, is that patients sort of are often in this cycle where they're, in the outpatient setting, quote unquote stable, and then they get admitted for acute heart failure, they get discharged, they might come back in with acute heart failure a couple times. In the setting of these cycles, they may progress in the hospital to death. Many of these patients will die in the outpatient setting with sudden cardiac death. And this cycle has been diagrammed, I think many of you are familiar with this, where every time the patient gets hospitalized, they deteriorate, but they never sort of go back up to their pre-hospital level of functioning. And then at a certain point, they sort of get on this rapid downward spiral where we start to think about, again, sort of therapies, advanced heart failure therapies, but we really want to try to catch patients and optimize their care before they're in this downward spiral and before they're in a setting where they're sort of in the hospital all the time. And, the issue, of course, for HFrEF, we've had therapies for many, many years, therapies that have shown to improve morbidity and mortality, but a lot of our patients aren't getting those therapies. So this is some data from the CHAMP-HF registry, was published a few years ago, that really sort of shined a light on how undertreated patients were with HFrEF based on old guidelines for what constituted guideline-directed medical therapy. So if you look at the number of patients who are on an ACE, an ARB, or an ARNI, it's only about 72%. And these are patients who don't have a documented contraindication for those therapies. If you look at patients who are on an evidence-based beta blocker, it's only about 2/3. And if you look at the number of patients who are on a mineralocorticoid receptor antagonist like spironolactone or eclarinone, it's only about 1/3. So, we can do better than this in terms of treating patients and administering the guideline-directed medical therapy that we know keeps patients out of the hospital and improves longevity. I also mentioned sort of this concept of dispelling the notion of clinical stability in heart failure. Many of us will see a patient in the outpatient setting and say, oh, you're stable, and we won't titrate medicines, we won't initiate new therapies, we won't change doses because they seem fine. And this is part of the reason why this new universal definition document really is trying to get us to sort of not use the term clinically stable and use a term like heart failure in remission. Like once a patient has a diagnosis of cancer and it's gone into remission, there's still sort of this fear, if you will, for us as clinicians as well as patients, that they could always relapse and get sick again. And this really should be the same type of thinking with heart failure. And this is some of the data that informs that. This is a post hoc analysis from Paradigm, which looked at patients who were enrolled in the trial and what their outcomes were. And of course, we know that patients who are the least stable, i.e. who had been hospitalized for heart failure within 3 months of screening and enrollment, 30% of those went on to have the primary event, which was a composite of CV death and heart failure hospitalization during the trial, but 19% actually died during the trial. If you look at the patients who we would otherwise call clinically stable, so they never had a prior heart failure hospitalization, 20% of those went on to have the primary composite event, but 17% died during the trial. So again, these are patients who'd never been hospitalized before, but still 17% went on to die. And in about half of those who were considered stable, who died during the study, the primary event that led to death was actually sudden cardiac death. So many of these patients, as I showed you in that diagram, will die suddenly without ever having had a preceding heart failure hospitalization. So this notion of clinical stability in these patients sort of really has to be dispelled. So because of that, and because of sort of all of the evidence that's sort of rapidly accumulating in this space, particularly for HFrEF patients, the ACC went back early last year, and updated the 2017 expert consensus decision pathway for optimization of heart failure treatment. So this is only for HFrEF patients. And I will say that the ACC AHA guidelines are not out yet. Those are expected to be published later this spring. But this is sort of what these documents say. So, so actually there's a couple of things that are different here. The first thing is that when you look at sort of foundational therapy for these patients, ARNI, ACE, and ARB are the preferred RAS inhibitors, but really the ARNI is the preferred agent. So many of us are seeing patients in clinic or in the hospital setting who are on an ACE or an ARB, and we really should be thinking about taking those patients off of those drugs and switching them to an ARNI. And I'll show you the data for that. Of course, an evidence-based beta blocker, as I mentioned. If I go backwards, actually, I think one of the other new things in this expert consensus decision pathway is that they changed sort of the recommendation for the use of hydralazine and isosorbide. And I think this is very relevant for us because of the demographics of the patient population that we take care of within Emory Healthcare. So for persistently symptomatic Black patients, despite an ARNI, a beta blocker, an aldosterone antagonist, or an SGLT2 inhibitor, at that point, you should think about adding hydralazine and isosorbide. So the idea now is that patients should be on 4-drug therapy. And if they're still symptomatic as Black patients, that we can consider adding hydralazine and isosorbide as a fifth agent. And then, of course, the other sort of new kid on the block would be the SGLT2 inhibitors for patients who meet the appropriate GFR criteria and who are NYHA class 2 through 4. So let's look at these in sort of detail. And again, just to sort of reiterate, I mentioned that the ACC AHA guidelines have not yet been published, but the ESC guidelines have already been published. Those were published last fall. And they also kind of established this idea that the 4 pillars of foundational therapy now for optimal management of HFrEF include the ARNI or an ACE inhibitor, beta blocker, MRA, or an SGLT2 and an SGLT2 inhibitor. As I mentioned, the ACC really sort of says to us the ARNI is preferred over the ACE or the ARB. So let's kind of come back to this concept of why the ARNI is preferred, because this is probably one area for many of us that is sort of a true change in clinical practice. So just to remind us of where that recommendation may have come from, of course, there's been multiple different clinical trials now that have been published showing the superiority of Sacubitril-Valsartan over ACE inhibitors. But we'll start with the first, which was the Paradigm HF trial, which was published now in 2014. So it's been almost 10 years. At the time, this was the largest heart failure trial that had been done, over 8,400 patients, EF less than or equal to 40%, who were NYHA class 2 through 4, randomized to Sacubitril-Valsartan or enalapril. And this was a really exciting study, in part because the primary outcome, which was a composite of CV death or heart failure hospitalization, was reduced, about a 20% relative risk reduction. But I think what was more exciting is that if you looked at all of the secondary individual endpoints like CV death, heart failure hospitalization, and even all-cause death, all of those were significantly reduced as well. And this was the first time in a long time that we had seen that the primary outcome reduction was driven by both a reduction in heart failure hospitalization and a reduction in cardiovascular death. But there were a lot of criticisms of this trial, as many of you are familiar with. And so the sponsors sort of came back and did a couple of other trials that I think, again, sort of reiterated the superiority of this drug over the ACE inhibitor. The first of those was Pioneer. So this was a smaller study. It was only done in North America, again, reduced EF less than or equal to 40. And these were patients who were admitted to the hospital with acute heart failure, and they had to have elevated natriuretic peptide levels. And this study was really only powered to show a reduction in NT-proBNP. So all of these patients, because they were in the hospital, sort of went through this careful dose titration algorithm. It's also important to realize that this was the first diagnosis of heart failure in about a third of them, and over half of them had never been on an ACE inhibitor or an ARB. And as I mentioned, this study was only powered to show a reduction in NT-proBNP, which it did, as you can see from the graph, over an 8-week period. But what was really powerful, I think, about this data was that when you looked at the secondary outcome of rehospitalization for heart failure, it was reduced by almost half in terms of a relative risk reduction. And again, the study actually was not powered to show that at all. We worry about safety in these patients, particularly patients who are hospitalized. And when you looked at key safety outcomes like renal function, hyperkalemia, symptomatic hypotension, or angioedema, there was no difference between the groups who were randomized to sacubitril-valsartan versus enalapril. I think one of the other really important studies that's come out in the last few years looking at sacubitril-valsartan has been the PROVE-HF study. So this was not a trial, it was a sort of a prospective 12-month open label study at about 78 outpatient sites in the US. And what they really wanted to look at in the study was the effect of sacubitril-valsartan on cardiac remodeling. We mentioned before that sort of it's important to follow NT-proBNP or BNP in part because we know that patients that have chronic elevations in those natriuretic peptides tend to be at higher risk for adverse outcomes, in part because it's indicative that the myocardium is sort of always under stress, always under injury. And what we saw in the PROVE-HF trial was if you start patients on sacubitril-valsartan, that there's about a 10% improvement in left ventricular ejection fraction, as I pointed out here, over a 12-month period. For some of the sort of budding cardiologists or cardiologists in the room, we tend to look at volumes of the ventricle to really see that the ventricle and the atria are shrinking in response to therapies that we've initiated. And if you look at left ventricular end diastolic volume index, in systolic volume index, left atrial volume index, or E to E prime, which is sort of a marker of intracardiac filling pressures, that all of those parameters improved over a 12-month period as well. So all of these comparisons are just significant. And the other thing that was important about the study was that at the time of enrollment, about 98% were already on a beta blocker, and 75% of these patients were already on an ACE or an ARB. So again, sort of establishing that even in patients who were on standard GDMT, by switching them to sacubitril-valsartan, you still saw the improvements that are diagrammed here. So what about the SGLT2 inhibitor? Because again, that's sort of the other area that I think is new and that many of us sort of may still be kind of coming to grips with some of this data. Well, I think, we now realize that there's indications for these drugs in multiple different disease entities, including diabetes, including heart failure, and including CKD. And we have a lot of patients in our system, of course, who have all three of these diseases at the same time or conditions at the same time. Many people are sort of starting to think of SGLT2 inhibitors as the statins of heart failure, if you will, because they have these sort of myriad and pleiotropic effects that really protect patients, high-risk patients, from not only incident heart failure, but also reduce morbidity and mortality once heart failure is manifest. And what are those pleiotropic effects? Well, we know that these drugs, by sort of blocking the uptake of sodium and glucose at the level of the glomerulus, that you reduce cardiac preload. There's also been evidence of improved systolic function as well as diastolic dysfunction, maybe decrease in fibrosis and improvements in ventricular remodeling. There's been some other studies that have shown improvements in endothelial function, vascular stiffness. We know that these drugs actually have been associated with reductions in uric acid. They've probably been shown at the level of the kidney as well as the level of myocardium to improve sort of overall metabolic efficiency. So they actually allow the heart to utilize non-fatty acid fuel like ketones and other fuels, which again sort of makes the heart operate more efficiently metabolically. And they reduce oxidative stress as well as improve natriuresis and improve fluid retention and edema. So these drugs have now been tested in a number of studies. I think the two studies that really kicked off this data set were DAPA-HF and EMPEROR-reduced. DAPA-HF randomized patients to dapagliflozin versus placebo on top of standard GDMT at the time. And again, you can see this was a positive trial. The relative risk reduction was about 25%. EMPEROR-reduced, same setup, looking at a primary outcome of CV death or heart failure hospitalization. To me, what's sort of fascinating is that the relative risk reduction was also 25%. So again, I think sort of solidifying the idea that this is really a class effect. It's not necessarily, I don't think, specific to any particular SGLT2 inhibitor, although for right now, the only two that are approved for the treatment of HFrEF are dapagliflozin and empagliflozin. There's also been data with sotagliflozin, which some of you may have seen that data, Soloist, which of course is an SGLT1 and 2 inhibitor. I think it's also important to point out that these outcomes have now been shown in multiple post-hoc analyses to be similar in patients who don't have comorbid diabetes. So again, we can start these drugs in patients who just have heart failure, whether they have diabetes or not, and the efficacy and effectiveness is really the same. So in terms of sort of the how-to, this is actually fairly simple. You just start the drug and go. There's no titration necessary. It's a target dose of 10 milligrams daily as compared to some of the higher doses that are seen for patients with diabetes. I think it's also important to realize these GFR criteria. So for dapagliflozin, this has only been tested down to a GFR of 30. We now have a couple of studies, both in HFrEF and HFPEF, that I'll show you later, that have tested this drug down to a GFR of 20. So in patients who have sort of more advanced CKD, I tend to choose empagliflozin. For patients who have relatively preserved renal function, I think either is fine. And of course, it's important to consider cost, because we know that sometimes one of these agents might be preferred in terms of the patient's outpatient formulary. So putting all of that data together, there was an analysis. This was a cross-trial analysis of data from a number of these different studies, including EMPHASIS-HF, which looked at spironolactone paradigm that we just talked about, in DAPA-HF. And what these investigators did was they tried to sort of compare what are the benefits in terms of event-free survival, which would be survival-free of death or heart failure hospitalization, or just survival alone, right, death. If we have patients on 4-drug therapy, which is ARNI, evidence-based beta blocker, an MRA, or an SGLT2 inhibitor, or I should say plus, as compared to conventional therapy, which is just an ACE or an ARB and a beta blocker, because I showed you the data from CHAMP-HF before, which shows that most of our patients, 70%, are not on an MRA. And this is what this analysis showed. So if you look at the difference in event-free survival, if patients are on 4-drug therapy, for a 55-year-old, you can get them over 8 years of event-free survival. Even for an 80-year-old, you can get them about 3 years, additional years of event-free survival if they're on this comprehensive therapy versus conventional therapy. If you just look at mortality alone, again, for a 55-year-old, we're talking over 6 years of additional survival. And for an 80-year-old, again, we're talking about 3 years of overall survival. So this analysis is really sort of one of the many that sort of formed the backbone of this sort of new paradigm that 4-drug therapy is the standard of care for patients with HFrEF. It's worth mentioning that there is another new kid on the block, which is vericiguat. Again, some of you may not be familiar with it. So just to sort of review the mechanism of this drug, we know that patients with heart failure, patients who have heart failure with CKD, diabetes, obesity, tend to suffer from endothelial dysfunction. They tend to have lower levels of nitric oxide. And that's important because nitric oxide, of course, simulates soluble guanylate cyclase to convert GTP to cyclic GMP. If you have nitric oxide deficiency and thus a cyclic GMP deficiency, these patients tend to have more myocardial dysfunction and more vascular dysfunction. So the way that vericiguat works is that it enhances the sensitivity of soluble guanylate cyclase to nitric oxide. It also directly stimulates soluble guanylate cyclase. So you sort of get around the decreased nitric oxide bioavailability, and you get increased conversion of GDP to cyclic GMP, and thus improvements in myocardial function as well as vascular dysfunction sort of throughout the cardiovascular tree. And this concept was really tested in the Victoria trial, again, a large trial, over 5,000 patients, EF less than 45%, NYHA 2 through 4. Again, you see the same sort of primary composite outcome that we usually use in heart failure trials, which is CV death or first heart failure hospitalization. And that primary endpoint was reduced, about a 10% relative risk reduction in patients who were randomized to vericiguat versus those who were on sort of standard GDMT. If you look at the secondary outcomes, cardiovascular death or all-cause death, those were not reduced. So really this primary outcome was driven by a reduction in heart failure hospitalization. I think it's also important to point out again, because we just established 4-drug therapy as the standard, that most patients in Victoria were not on 4-drug therapy, right? All of these studies have sort of been happening at the same time. But it is sort of important to realize this drug is FDA approved at this point to reduce the risk of CV death and heart failure hospitalization following a heart failure hospitalization or a need for outpatient IV diuretics within the past 6 months. And again, this is for patients who are an EF less than 45%. So if you did have someone who was on 4-drug therapy, maybe couldn't tolerate some component of the 4-drug therapy, but was hospitalized or needed outpatient IV diuretics, this is an option for those patients. And again, we've got a lot of stuff to choose from at this point to treat HFrEF. So again, reestablishing that modern day first line GDMT for these patients is really the ARNI, an MRA, an evidence-based beta blocker, or an SGLT2 inhibitor. It's important to think about repleting iron in these patients. And then we want to go back and assess how the patient has responded. You might decide to check an NT-proBNP. Of course, there's a lot of interest in other types of omics that we can do to really establish sort of the level of illness in these patients. And then you want to consider what other options might be available for your patient if for some reason they don't have the response that you would like to see. You could add vericiguat. Of course, if they're an African-American patient, you could add hydralazine isosorbide, maybe ivabradine for patients who still are tachycardic on a maximum tolerated dose of a beta blocker, or consider referring for advanced therapies because you've not been able to achieve remission in heart failure for your patient. So what about chronic HFpEF? Again, exciting because we now have options for those patients as well. So let's sort of review that data. The first randomized trial that was published in the HFpEF space in the last couple of years was Paragon-HF. This was almost 5,000 patients, NYHA 2 through 4. These patients all had an EF greater than or equal to 45%. They did have elevated natriuretic peptides, and they had to have evidence of structural heart disease. And they were randomized to treatment with Sacubitril-Valsartan or Valsartan. Again, you see the same primary composite outcome, which is total heart failure hospitalization or CV death. Unfortunately, this trial sort of just missed the mark, p-value 0.06. The confidence interval sort of just crossed 1, even though the overall trend was in the right direction in terms of reductions. If you look at heart failure hospitalization as one of the secondary endpoints, again, that was reduced by about 15% relative risk reduction, and that confidence interval sort of just hit 1. But if you look at some of the other secondary endpoints, like a sort of a renal composite outcome in terms of renal protection, improvements in NYHA class, those actually favored patients who were randomized to Sacubitril-Valsartan. And we know from the subgroup analysis that this data also showed perhaps a greater benefit in women who were on Sacubitril-Valsartan compared to Valsartan. We know that HFpEF is more common in women, and also patients who had an ejection fraction less than the median, 57%. Just last year, we saw the Emperor Preserved trial published, which is data for Empagliflozin in chronic HFpEF. So this was, again, a big trial, almost 6,000 patients. They had to have evidence of structural heart disease or heart failure hospitalization with 12 months of screening, as well as elevated natriuretic peptides. Again, now we're still including patients with type 2 diabetes and those who don't have type 2 diabetes, and they had to have a GFR above 20. And again, now we're sort of looking at the efficacy of empagliflozin versus placebo on top of standard care in HFpEF, which at that time there's not really much, right, in terms of standard care for HFpEF. If you look at the primary endpoint, for the first time, we see a positive trial, a very positive trial, if you will. So about a 21% relative risk reduction for those patients who were randomized to empagliflozin. Again, if you think back to the relative risk reduction in DAPA-HF and Emperor Reduced, it was about a 25% relative risk reduction. Here, we're seeing something sort of along the same lines, about a 21% relative risk reduction. So again, sort of highlighting the concept that this may be a class effect for these drugs. And there's a couple of other studies that we expect to be published within the next year or two, showing hopefully the same type of trend with drugs like dapagliflozin, where we may have multiple options for patients with HFpEF. There's also been some data showing the efficacy of empagliflozin in patients who are hospitalized with heart failure. So again, these are patients with or without diabetes who have either HFpEF or HFrEF. This was data that was shown at AHA last year, and I think has now been published in the last week, the EMPULSE trial. In this analysis, they used sort of a complex statistical analysis called a stratified win ratio that looks at sort of a composite of clinical benefit characterized by time to death, frequency of heart failure events. Bottom line, this analysis favored patients who were randomized to empagliflozin versus standard of care. So again, sort of establishing that the SGLT2 inhibitors really do have benefit in patients with heart failure, perhaps regardless of ejection fraction. So there's now been a number of post-hoc analyses with Sacubitril-Valsartan, sort of looking at its benefit across the spectrum of ejection fraction. Empagliflozin, as I just showed you, looking at its benefit across the spectrum of ejection fraction from the Emperor Reduced and Preserved trials. And what we can see is that there's really benefit in patients for Sacubitril-Valsartan Certainly, once we start to get below sort of a normal ejection fraction, maybe 55 to 60%, and that benefit seems to get more impressive as the EF goes down, and you see the same type of trend with empagliflozin. So both of these drugs are now approved for treatment in patients, regardless of ejection fraction, if you will. You can prescribe Sacubitril-Valsartan to patients with HFrEF or HFPEF, with the sort of caveat that the benefits are most clearly evident in patients with an EF below normal, and the FDA told us to use our clinical judgment in terms of deciding whom to treat. And just as of a few days ago, empagliflozin is now approved for the treatment of HFpEF. So for those of you who may have been trying to prescribe this and getting rejections from insurance companies, hopefully that will start to change over the next couple of weeks to months. So let's try to apply some of this to a case, because I know this was a lot of information. So this is a patient AR who's probably fairly typical of patients that we see here at Emory. He's a 65-year-old Black man. He was admitted to EUH for management of acute heart failure, and this is actually his third hospitalization for heart failure in the past year. He has an EF of 25%. He also has diabetes, hypertension, and stage 3B CKD. He's actually on, not bad medicines. His medications include Sacubitril-Valsartan, 4951. He's on metoprolol succinate, metformin, glipizide, atorvastatin 80, aspirin 81, and torsemide 20 daily as an outpatient. So when you admit him, he's got a blood pressure of 106/84. He's got 3+ lower extremity edema and JVD to the angle of the jaw. His A1C is not bad at 7.3, and his GFR is 38. And so the question is, how would you optimize his medical management? Would you add spironolactone? Would you add dapagliflozin? Would you just give him IV diuresis while he's inpatient and then increase his torsemide on discharge? Or would you add hydralazine and isosorbide? And I know we don't probably have set up for audience response during this, but you guys could type your answers into the chat. But I would say actually that probably all three of these are reasonable for him. Or at least the top three, I should say. He's not on an MRA, so we do want to think about adding that, and his GFR is above 30, so that's okay at this point. We could add dapagliflozin. His GFR is above 30, again, so that's reasonable, and he's got diabetes, so they're really, and he's got CKD, so there's sort of really no reason that he shouldn't be on an SGLT2 inhibitor. I think, he's coming in very volume overloaded, so it's definitely reasonable to think about diuresing him and making sure that he doesn't go home on the exact same dose of diuretic that he came in on, because he's clearly failed that regimen. So I think the point of this case is to sort of realize that many of our patients are coming into the hospital, they're just getting diuresed, and then they're getting sent home on the exact same therapies that they came in on. And with all of the wealth of data that I've just shown you, that really is, I think, sort of us failing our patients with heart failure. We really should be thinking about trying to optimize them. And in many ways, the acute setting is the perfect time to do this. And there actually was, again, another expert consensus decision pathway that was published a couple of years ago, really saying to us that the hospitalized setting is the perfect time to assess our patient's clinical trajectory and figure out if they are improving. And if they are, to think about using that hospitalization to transition them to oral therapies and optimize their GDMT. But then for patients who aren't improving, to think about what other options are available. So again, when patients are hospitalized, we need to do what they call a trajectory check. If they're improving towards their target, if they're tolerating decongestion, fine, get them diuresed, but consider optimizing GDMT, which may mean starting, spironolactone, or starting an SGLT2 inhibitor in one of these patients while they're in the hospital setting. Again, sort of how to do this, even how to start these drugs and change them has changed. Many of us were taught to add one drug, titrate it to the doses used in the clinical trials, and then add the second drug and titrate it to the doses used in the clinical trials. And now the thought is to do what's called rapid sequencing. So to try to get these patients on all 4 drugs as quickly as possible, in this case, within 4 weeks. If you look at that ACC expert consensus decision pathway, they actually say to us, bring the patient back if you're doing this in an outpatient setting, and assess their response within 2 weeks, and either start the next drug or titrate the drug that you've just started. But the goal is really to try to get patients on all 4 drugs as rapidly as possible to reduce morbidity and mortality. So let's say we did that for our patient. Let's say we started him on dapagliflozin, and we increased his torsemide to 50 milligrams a day. prior to discharge. And yet despite that, so now he's on, 4-drug therapy, he's on an ARNI, he's on an evidence-based beta blocker, he's on an SGLT2 inhibitor, and he's on, sorry, I should have put spironolactone here. So let's just pretend like he's on spironolactone. And yet despite that, he still comes back to the hospital with dyspnea on exertion within 10 days of discharge. So again, this is something that we see a lot of here, right? 30-day readmission. And we look at his exam, he still has sort of a blood pressure that's marginal, if you will. He's a little tachycardic, he's edematous again, his JVD is back up, his kidney function seems reasonable. And so now what do we do? And again, I think this is a time to sort of realize that unfortunately our patient, maybe had some initial improvement, but he's stalled, or you could also even sort of say that he's not improved and he's worsening. And so the questions at this point are, can we escalate his current therapy? I forgot the spironolactone, but again, we're going to pretend like he's on that. But the other question is, does he need, an invasive hemodynamic assessment? Is this someone whose heart failure we can't get into remission? And maybe he's someone who's approaching stage D, and we need to consider advanced therapies for him and assess his sort of overall prognosis. So we tried to highlight some of these issues in a guidance document or a scientific statement that I led with the AHA last year that was published, sort of really trying to speak more to the non-heart failure clinician than the heart failure clinician, because one of the things that we see in the advanced heart failure space is, unfortunately, sometimes these patients only come to us when they're in extremis, as I mentioned before. They only come to us when it's time to, be started on ECMO, or when they're already on, an inotrope. And we really ideally want to see these patients in an outpatient setting, if possible, or at least sort of consult, not necessarily on the day of discharge, but to be able to lend guidance to how to help titrate this 4-drug therapy or other drugs while the patients are in the hospital. There are a number of clinical clues that can tell you that a patient may be approaching stage D or has frank advanced heart failure. And I think oftentimes, because we see so much heart failure within Emory Healthcare and within many healthcare systems, we ignore these symptoms. So those patients who have persistent NYHA 3 through 4 symptoms, despite GDMT, patients who are hospitalized frequently. So if you have a person who's been to the emergency room or been hospitalized for acute heart failure more than 2 times in the past 12 months, that should be a red flag. And again, we see a lot of this within our healthcare system. And again, I'm assuming that, we're assuming that our patients are adherent. And many times patients aren't adherent with drugs because they're not tolerating them. We hear patients all the time say, I took my carvedilol and I got, nauseous, or I felt terrible and had to lay down. And so sometimes intolerance of GDMT is the reason that patients are non-adherent, and that in and of itself should be potentially a sign that patients have advanced heart failure. Patients who don't tolerate medical therapies because they're hypotensive or dizzy or have worsening renal function. Patients who have a high-risk biomarker profile, like I mentioned, those patients who you've gotten them as diuresis, you think you're going to get them, but their BNP is still greater than assay. That's a patient who may have advanced heart failure. Patients who are having worsening atrial fibrillation, VT, particularly with ICD shocks. Patients who you're having to continue to go up on the doses of the diuretics or continue to be edematous despite escalating diuretic doses, or of course patients who have a need for IV inotropes. And as I mentioned, all of these signs and symptoms, the common ones, of course, are patients hospitalized frequently, and those patients who are not tolerating guideline-directed medical therapies, like our patient, Mr. AR. So in this document, we really sort of tried to hopefully give some guidance for who you could think about referring to the advanced heart failure clinic to ask the question of whether or not they're a candidate for advanced therapies. Oftentimes, again, patients are referred to us sort of to only ask the question of whether or not they're a candidate for a VAD or a transplant. But there's a lot more that we have to offer people in the advanced heart failure clinic than just VAD or transplant. We know that we have, pulmonary artery pressure sensors that we can offer patients who are hospitalized frequently. I mentioned all of the GDMT that is now available that oftentimes can be difficult to start in the outpatient setting, but this is something that we sort of do all the time, even in the setting of blood pressures that are marginal, as with our patient. And of course, hopefully we're expert at sort of assessing whether or not patients can tolerate these drugs. And if they don't, then sort of assessing whether or not they may be a candidate for advanced therapies. I think the point here is that oftentimes we're seeing patients when the referral comes too late, when they already have advanced renal function with dysfunction, when they already have congestive hepatopathy and perhaps early signs of cirrhosis, ascites, all of these things that really could have been prevented had the consultation with us sort of come earlier in the patient's trajectory. We even, sort of sometimes talk about cardiac cachexia. In our patient population, again, we see a very, very high prevalence of obesity, but sometimes these patients, have gone from a BMI of 38 to a BMI of 31 or 32 over a 6-month period, and that's cachexia, right? They're still obese, but they're losing weight rapidly because of advancing heart failure. And it's important to sort of pick up on these things, again, before we're placing referrals that are too late and before we don't have anything to offer them. So in summary, hopefully just to leave a couple of minutes for discussion and questions, hopefully I've convinced you that the landscape of medical therapies available for treatment for both HFrEF and HFpEF has rapidly evolved and continues to rapidly evolve. There's actually a couple of drugs that we didn't even talk about today that I think will be FDA approved within the next year or two. It's important, again, to remember that heart failure prevention is something that we want to do and implement for patients who are at risk or with pre-heart failure, because these are the largest group of patients that we take care of. They really should be treated with medical therapy that can prevent the onset of heart failure. And again, in those patients who are pre-heart failure, even though they're asymptomatic but have evidence of elevated natriuretic peptide levels or structural heart disease, you can consider referring them to a cardiologist for further diagnostic and treatment strategies to, again, hopefully prevent them from progressing to manifest heart failure or stage C. In those patients who do have stage C heart failure, again, we established that ARNI plus an evidence-based beta blocker plus an MRA plus an SGLT2 inhibitor is now considered the new standard of care. So we should really be trying to get patients on this drug combination unless there's a clear contraindication. And that contraindication may be financial. It's important to point that out, but this should still sort of be our goal. And we now have evidence of the benefit of the ARNI compound as well as SGLT2 inhibitors across the spectrum of ejection fraction, including in those with HFpEF. And then finally, for those patients who are approaching or are frankly stage D, really consider referring them to a heart failure specialist according to their goals of care so that we can hopefully evaluate whether or not they would be a candidate for advanced therapies. So I will stop there and hopefully allow some time for discussion.
Thank you, Alanna. Thank you for that really wonderful and very high yield review of new classifications and standards of care. I want to ask Jason Williams, he had an early question in the chat box that you touched on briefly about rapid sequencing in terms of starting quadruple therapy. Jason, do you want to talk a little bit more about what your question is?
Yeah, thanks, Dr. Law. Dr. Moore's wonderful talk. I really learned a lot. I'm a hospitalist that specializes in heart failure at the VA and ultrasound as well. We auto consult on a portion of our acute decompensated heart failure patients and provide semi-quantitative assessments of pulmonary edema, leg edema, and objective measurements of central venous pressure, and work with cardiology and nephrology to guide volume status. And while we've been doing this quality improvement, I was like, well, I'm here, I might as well work on goal-directed medical therapy. And so my goal is to get 4 therapies like potentially on board before they go home, but some of the heart failure hospitalizations can be short and my veterans don't get the follow-up labs I order like more than half the time. And so they may not get a potassium or creatinine check for a month or 2, let alone blood pressure. And so what we've been doing is starting SGLT2s on day 1 because it augments diuresis, and then titrating up ARNIs or off of ARBs. And there's like a washout, you got to watch out when you do that. If their blood pressure tolerates, once they have good urine output. And then we usually sprinkle on a beta blocker at the time of discharge, but I always feel nervous then throwing spironolactone or eplerenone on top of that on the day of discharge without knowing what's going to happen. Do you have any recommendations there?
Yeah, I think, and I know that Andy has his hand up because Dr. Smith, he and I had this discussion yesterday, so I'll let him sort of weigh in too. I'm giving you the guidelines, but I mentioned a couple of times it's important to use clinical judgment, right? So this is sort of a hot debate, I guess, if you will, even within the heart failure space of whether or not adding drugs and titrating every 2 weeks, for example, right? I said every 2 weeks, the length of stay for a patient with acute heart failure might only be 4 or 5 days. You may not have enough time to do this. There are reasons to try to be aggressive. You mentioned, for example, sort of adding the SGLT2 inhibitor early may augment diuresis. There's also data that shows that adding the SGLT2 inhibitor actually decreases the risk of hyperkalemia after you add the MRA, So there's a lot of potential reasons for that rapid sequencing. That being said, in reality, it's really difficult to get a patient back to clinic in 2 weeks to assess response and then keep changing the drug, right? Patients have side effects. People get dizzy. We know when we start the SGLT2 inhibitor that the creatinine or the GFR, will go down, just sort of as a marker that they're responding to the SGLT2 inhibitor. I've had patients, now that they can see their labs online, they're like, what did you do to my kidneys? I'm like, well, I actually did something good for your kidneys if you wait a little bit of time, but sometimes they freak out. And, the sort of guidelines and then implementing the guidelines for many of us in clinical practice are two very different things. So I have young women in particular who I've taken off of ARNI therapy because they get dizzy, they feel really tired, and they feel way better when I went back to their ACE inhibitor or the ARB. So I think, sort of understanding what the guidelines tell us, but then applying them to an individual patient is what makes us, sort of good clinicians. And that can be really difficult. Dr. Smith, did you want to sort of weigh in and add to that?
Yeah, I'd called Alanna yesterday because there's a difference between guideline-directed medical therapy and necessarily evidence-based medical therapy. So when we did the trials with Sacubitril-Valsartan, we learned that often patients' diuretics needed to be decreased for them to be able to tolerate it. The trials that you see are trials in which things were added. And now suddenly a group is coming out and saying, start them all at once, start all 4. And there's potential danger to that. In particular, in putting patients on spironolactone who may get volume depleted. You're going to see some hyperkalemia. So I've got some reservations about the current jump out there and prescribe all 4 at once, particularly for someone who has not been hospitalized. And we'll just kind of follow where this is going, but it's not the way. What's being recommended is not the way the clinical trials were necessarily done. And just a reminder that in the Sacubitril-Valsartan study, 20% of people did not tolerate that drug during the run-in phase. And another reminder is that the best scientific data for improvement in heart function is with the approved beta blocker therapy with up titration of those drugs. And hopefully people aren't going to run into problems with up titrating beta blockers at the issue of having hypotension. But yeah. Alanna, fabulous talk. And just one other comment is that, when we tell somebody we're giving them a drug for cancer, they don't ask us what the mechanism is. They want to know what the side effects are. Mm-hmm. And yet when somebody asks us, what does this drug do for me? For some reason we say, oh, well, it lowers your blood pressure, it lowers the resistance. The reality is that it makes you live longer, it prevents you from being hospitalized, and it makes you feel better. And that's the approach we need to take. So yeah. Fabulous talk.
I think these are all good points. I mean, in my own clinical practice, I rarely start a bunch of stuff all at the same time. Because again, if someone does get side effects, I want to know which drug caused the side effect. But I think the other sort of corollary to this is, as you guys have sort of, very astutely pointed out, is we want to try to avoid clinical inertia, right? So now that we have all of these fabulous drugs that are associated with improvements in morbidity and mortality, what we don't want to do is what was shown in CHAMP-HF, which is that we've got all these patients who are eligible for the drugs, but they're just not getting them. But we still have to sort of apply our clinical judgment and use them in the right spaces and titrate them in a way that hopefully won't cause side effects and helps patients understand that we can hopefully prevent them from getting hospitalized, prevent them from dying, and make them feel better.
That's phenomenal. Well, we're just on the hour. And so thank you, Dr. Morris, for this comprehensive review, which I do think has prompted so many people who have been listening away from clinical inertia. And then also thank you, Dr. Smith and Dr. Morris, for the helpful contextualization of this. I think we had lots of clinicians that were ready to write quadruple prescriptions today. And so I think it's really helpful for us to understand that this is a work in progress, that there is a delta between sort of our desired outcomes, what we have available to us, and how we usher our patients over there. So thank you. And then just one additional comment, Dr. Sperling, who joined us today, had a great comment about the importance of cardiac rehab, which I always find is always helpful to remind that there are non-pharmacologic therapies that are extremely effective in helping our heart failure patients as well. All right. Thank you very, very much. Have a great day, everyone.